name is Nguyen Dinh Chau from the Department of Radiation Oncology, Radiology Nuclear Medicine Hospital, Vietnam. The first was I would like to thank you for inviting me to give a mini oral presentation in IUCS 2025. And today I'm honored to talk about our study results on the implementation of moderate hypofractionated radiotherapy for patients with localized prostate cancer. Prostate cancer is one of the most cancer among men worldwide. According to global data, it ranks among the leading malignancies in terms of incidence and mortality. In Vietnam, we have also observed an increasing number of newly diagnosed cases in recent years. Even with good prognosis, the disease remains a major public health concern. Multimodalities strategies are available for localized disease, including active surveillance, surgery, radiotherapy, and ADT, depends on risk group classification. The management of prostate cancer has a long history, with surgery and radiation therapy recognized as the earliest definitive treatment approaches. Even from randomized trials have shown that radiotherapy provides outcomes comparable to surgery in terms of disease control and overall survival. This picture shows hypofractionated radiotherapy can help to reduce treatment time, hospital visits, and healthcare burden. Those benefits became particularly important after the COVID-19 pandemic in many diseases. Importantly, clinical evidence emphasizes that hypofractionated schedules are not inferior to the conventional fractionation radiotherapy in similar disease control and toxicity profile. With the support of IA through the RAS-6100 project, our center has successfully implemented hypofractionated radiotherapy in several cancers, including prostate. So we conducted a prospective single institution study from 2020 to 2025. The purpose is to evaluate the early results of moderate hypofractionated radiotherapy for localized prostate cancer patients. The inclusion criteria were biopsy show prostate adenocarcinoma, CT1 to 3, N0, M0, ECOG 0 to 1, and patient refused radical surgery. The exclusion criteria as follows: history of primary irradiation and other cancer within the past 5 years, a patient with acute proctitis or cystitis, and severe comorbidities. This figure highlights the radiotherapy workflow for prostate cancer radiotherapy in our center, including CT simulation, treatment planning, patient-specific QA, accurate positioning and delivery, and follow-up. According to international guidelines, radiotherapy is combined with ADT for intermediate and high-risk patients with treatment duration tailored to risk level. One patient underwent CT simulation with strict preparation, empty rectum, comfortable full bladder, and we use valve for immobilization. From our patient data analysis, we have derived several formulas for calculating bladder volume and determining its optimal value, thereby providing the quality of simulation and treatment planning. We also use MRI fusion for precise target delineation and daily complexity for verification before treatment. This picture illustrates the research process. All patients underwent hypofractionated radiotherapy with total dose of 60 gray in 20 fraction to the prostate, with or without seminal vesicle by tubing estate system plus ADT. Then they were followed up every 3 months to collect data for survival and toxicity analysis. Our results show the majority of patients were classified as high risk. Most of them presented with initial PSA level more than 20. Gleason score higher than 7 accounted for nearly 60%, and approximately 90% to tumor stage were T2 and 3. Prior to radiotherapy, about 90% patients had received ability to reduce PSA and target volume before radiotherapy. And the median follow-up time was 38 months. Here we can see the sharp decline in mean PSA level after radiotherapy, from more than 50 at the baseline to 10 before RT, and followed by sustained suppression below 0.5 during subsequent follow-up. This indicates a significant biochemical response and effective disease control achieved by radiotherapy combined with hormone therapy. The Kaplan-Meier curve illustrates at nearly 5 years of follow-up, biochemical relapse-free survival and overall survival remains above 90%, indicating excellent disease control and favorable survival outcome. Only one patient have died from bone metastasis. This table presents early adverse events after radiotherapy, showing that most acute toxicity were mild to moderate, with no severe events. The most frequent was cystitis and proctitis, being around 30%. Regarding late side effect, one patient suffered from grade 3 proctitis, and he recovered by local intervention eventually. In summary, moderate hypofractionated radiotherapy in localized prostate cancer show excellent survival and low rate of serious side effects. This modality should be applied more widely in high-volume radiotherapy centers in Vietnam. Of course, further studies with larger sample size and long-term follow-up is needed to assess in Vietnamese patients. And finally, I would like to sincerely thank my colleagues, our patients, and the organizing committee of IUCS 2025. Thank you very much for your attention.